this is the next part, and we're continuing. So we're talking about the exposure of newborn babies or preterm babies or babies who've acquired an infection in a high-risk environment. And preterm babies obviously are at high risk for this, but this is a problem. We need to know if mom has a active herpes outbreak before delivery, because we're trying to prevent this from occurring. This has a higher degree of mortality with newborn babies, especially preterm babies. I've read a couple research reports, and in one it said the pre-antiviral, before the antiviral medications came along, that the mortality rate for these infants was about 85%. Our rates of mortality have come down significantly. However, when you're talking about a preterm baby or a baby who has acquired this infection, their risk of mortality is much higher than another child without. And their immune system is so immature, their ability to readily fight this is not thoroughly developed, and depending on when mom acquired this, she may not have even developed enough antibodies to give to the baby to try to help the baby fight this. So most research reports basically say that human herpes simplex virus infections in the neonate can have devastating outcomes, including mortality and significant morbidity. So we try to, if we can, find out if mom does have this condition. If she does, and she has an active outbreak, we're going to look at alternative methods of delivery. She may end up with a C-section. About 85% of babies that contract herpes get it from mom during vaginal birth. There is some research and some questions. Are some of these an ascending infection, like meaning the virus spread up into the uterus and it transcended the mucus plug? So there is some questions and research that's still being looked at. It is estimated that about 10% of babies do contract this or acquire this in the postpartum environment. I actually just read a case study of a baby who contracted herpes, but not the genital type, from a cold sore from a visiting aunt who had an active cold sore lesion and was kissing the baby. So that is a lesser degree, it's still a risk. They estimate about 5% or less it's contracted in uterine without being exposed to mom's vaginal tract. This is sometimes where the baby's skin came in direct contact with mom's mucous membranes and the active lesions. You may see these lesions develop on the baby, and you're looking at a preterm baby, a 34-weeker. This could have a devastating outcome for this child. They can develop hepatic lesions in their mouth. So don't just assume something is thrush. Again, it's direct contact with mom's mucous membranes at birth. There are some symptoms. If this was contracted earlier in pregnancy, then you're looking at the microcephaly, the mental delays, the mental the long-term effects on their cognition and mental development. But they can also develop seizures. It can affect their eyes, their respiratory status, and it can affect the baby's brain. This is a baby that is developing organ failure secondary to a herpes infection, where it actually even spread to the brain and caused encephalitis. And that's what I mean when I say this can be a devastating condition. That's why it's important to have a very good history on mom, and for her to get really good prenatal care for us to try to prevent some of these infections from happening. Then you have rubella, which can its exposure in utero can lead to some long-term effects, but it also can cause blindness. And we talked about CMV already. When you look at rubella, some of the symptoms that you might see at birth: congenital cataracts. The baby may fail a hearing test. may have some congenital heart defects, and sometimes the infection can be fatal. So we really try to immunize mom and to prevent this, and we immunize her when she is not pregnant. And then the syphilis, we're under the O for other. This can also be given to baby. It can be acquired from mom. Some of the symptoms that you might see is rhinitis, excoriation of the upper lip or the mouth. They can have a red rash around their mouth or their anus. They'll have this kind of colored rash of the face, the palms, and the soles. They may be more irritable, have edema, and the baby can be born with cataracts. We can treat this. We're going to culture the baby's orifices. They're going to try to identify what it is, and we're going to give the baby penicillin. This is a baby that has congenital syphilis from mom. So contracted this condition from mom. Hepatitis B is a risk. We talked about this extensively in the normal newborn baby, but I just want to bring it up that again, that if mom's history is questionable or we are unsure of her status, her hepatitis B status, that they can give the baby hepatitis B immunoglobulin and then start the baby on the regular 3-shot series of hepatitis vaccination. And I should say that hepatitis it's transmitted by body fluids, so it can be found in breast milk, and the baby can acquire it from direct contact with mom's mucous membranes during delivery. What are our interventions with working with a baby who's, has impaired or immature immune system? And what kind of interventions do we put in place to try to protect babies? Well, if you have gone to NICU, and several of you have, one of the things you're going to notice is we're very, very, I don't want to use the word hypervigilant, but we kind of are about making sure that everybody who comes to the unit wash their hands. They're going to scrupulously clean the unit. You're going to teach the family when each time they come to visit how to scrub their hands. We're going to try to maintain infant skin integrity, try to not use adhesives. Sometimes we don't have a choice, but we will try not to. So instead of using adhesives, we may put a device on and bind it with Curlex instead of using tape. We're going to try to avoid using really strong chemicals on the baby's skin to avoid injuring the skin, and we're going to frequently change the baby's position to decrease the risk of the baby developing breakdown. We sometimes will have to put the baby on reverse isolation. We have strict hand washing policies for visitors and staff. They'll have strict policies about food and all kinds of things in the baby's environment. We use single infant equipment, so we'll have equipment designated for each baby. When you're working in that environment and you're interacting with high-risk babies, some of the things that you're going to learn to implement is you're going to want short fingernails, no artificial nails or chipped nail polish, no gel nail polish, anything where bacteria can hide under, because their immune systems are so immature. We don't want to risk where one of the nursing staff is actually causing a baby to get a pretty serious infection, which can end up to be sepsis. We're going to use very good sterile technique with our invasive procedures. They're going to clean the isolates weekly. They may use frequent positional changes using resources such as like sheepskin cloth, or a type of cloth that has a little bit more give to it, not enough to cause airway obstruction. I don't want to get that, but it's protecting their skin. And we're going to be very careful about using tape directly on the baby's skin, and we're going to be alert at all times for symptoms of infection. The next high-risk issue we're going to talk about when dealing with a high-risk newborn is issues with pain. Infants in the NICU undergo many painful procedures, and pain can be a stimuli. And remember, we're trying to decrease the stimuli on this baby. Pain can cause physiological and behavioral changes, and so most facilities have either a FLAC assessment or a NIPS assessment. It's a pain way of assessing pain in a newborn baby. So we're going to assess babies for pain. You're going to, depending on your hospital protocol and what's happening with your baby, with procedures that they may be undergoing, you will have very specific times when you'll have to do a pain assessment. You want to assess how they're tolerating painful stimuli, and do we see changes in their vital signs, in their intracranial pressure, how does it affect their pulse ox rates. And sometimes if they have an audible cry, you'll hear them cry, but sometimes they just make the cry face. So we'll do interventions. They may give them pain meds just like we do older children and adults. We may use IV caffeine. We may use other IV types of medications to address their pain needs. These are some of the common signs of pain in the newborn baby. If they have an audible cry, they'll have a high-pitched, intense cry. You can tell something's wrong kind of cry. Or if they don't have an audible cry, they're really preterm. They may have the cry face. They may squeeze their eyes closed and hold their eyes closely tight. They may open their mouth and grimace, flail their extremities if they have the neuromuscular ability to do so. You can see color changes, vital sign changes, changes in their O2 sat rate, and in their intracranial pressure. So some of the things that we're going to do to try to intervene, these are kind of our nursing interventions for pain. We may use the Sweetie solution. We talked about that already in the normal newborn. They may give them a pacifier to suck on, talking softly, gently touching them, not a lot of stroking, because sometimes babies can't handle a lot of stroking. We may use containment restraints, not to kind of make them feel, because preterm babies are not ready to be born yet, and they're used to having to be in a contained environment. So containment pillows sometimes are comforting to them. We'll do frequent positional changes, IV meds, holding them, rocking them if we can. When you're looking at this, preterm babies generally have a difficult time with stress from the NICU environment and attaining adequate nutrition. So it's one of our things that we focus on. And parents may have a difficult time bonding with their baby. The baby's hooked up to all these devices with all these tubes, and you have all these nurses coming and going, and it's intimidating to them. They're scared and they're worried. So we're going to try to include them in this process. And one of the ways I try to include parents is having them participate in things like feeding the baby, or being there when we're doing certain procedures on the baby, so they can be a part of what's happening with their baby. The environment of the NICU environment, even though we try really hard to have a low stress environment, there's going to be noise, there's going to be bright lights, there's going to be sounds and alarms going off. So again, we're going to try to schedule periods of undisturbed rest to give their body a chance to rest and not have their little systems or immature be overwhelmed by trying to meet their own metabolic needs. We're going to try to reduce that stimuli. If there's loud talking or noise, we're going to have that taken away from the baby's immediate care environment. So we're going to promote quiet, restful periods. We're going to have scheduled naps. We are going to promote motor development, and most hospitals do have NICU, or that a level 3, level 4 facility may have sometimes physical therapists or occupational therapists that actually work with babies in the NICU environment. We're going to try to minimize pain. We're going to try to communicate the infant's needs to the parents. We do have nurse practitioners. We do have that sometimes are there when the physician isn't there. So we have advanced practice nurses who also work in the NICU environment. And sometimes the parent may just want to talk to somebody. They just want to talk to someone more than you as the nurse. But I always tell them that we try to include them in care, and they have lots of devices now that can include parents. If they want to take notes or pictures, we will do that. Some facilities actually have a video type system or a camera system, so the parents can check in and see their baby throughout the day if they have to be at home or someplace else while their baby is in the NICU environment. So we want to try to include those as much as possible, and I already talked to you about the containment pillows and the containment devices that we use.